Here's a detailed explanation of 15 major differences between Binswanger's disease and Krabbe disease. 1. Nature of disease. Binswanger's disease is a vascular disorder of the brain, specifically a type of subcortical vascular dementia. It arises from chronic damage to the small arteries supplying deep white matter. Krabbe disease, on the other hand, is a genetic metabolic disorder classified as a leukodystrophy, a group of diseases that destroy the myelin sheath in the central and peripheral nervous systems. 2. Cause. In Binswanger's disease, the cause is chronic small vessel arteriosclerosis leading to reduced blood flow and ischemic injury to the deep white matter. In Krabbe disease, the cause is a deficiency of the enzyme galactocerebrosidase, GALC, due to a mutation in the GALC gene, which leads to toxic accumulation of galactolipids, especially cytosine. Inheritance. Binswanger's disease is not inherited. It is an acquired condition linked to vascular risk factors like hypertension and diabetes. Krabbe disease is a hereditary disorder inherited in an autosomal recessive pattern. Both parents must carry one defective copy of the GALC gene. 4. Age of onset. Binswanger's disease primarily affects elderly individuals, typically over the age of 60. Krabbe disease commonly presents in infancy, usually between 3 to 6 months of age, though juvenile and adult onset forms also exist but are rarer. 5. Pathophysiology. In Binswanger's disease, chronic ischemia due to small vessel narrowing leads to degeneration and demyelination of subcortical white matter, disrupting communication between cortical and subcortical structures. In Krabbe disease, the lack of GALC enzyme prevents the breakdown of galactocerebroside, resulting in accumulation of cytosine, a toxic substance that destroys oligodendrocytes, leading to widespread demyelination. 6. Regions of the brain affected. Binswanger's disease predominantly affects the deep subcortical white matter, especially periventricular regions, centrum semiovale, and internal capsule. Krabbe disease affects both central and peripheral myelin, involving white matter in the parietal, occipital, and periventricular regions, as well as peripheral nerves. Clinical presentation. Binswanger's disease presents with progressive cognitive decline, executive dysfunction, gait disturbances, urinary incontinence, and pseudobulbar palsy. The dementia is often subcortical, meaning slowed thinking and reduced attention rather than memory loss alone. Krabbe disease presents with extreme irritability, stiffness, hypertonia, feeding difficulties, developmental regression, spasticity, and often seizures in infants. 8. Course of illness. Binswanger's disease has a chronic and slowly progressive course, sometimes with stepwise deterioration due to repeated vascular insults. Krabbe disease, especially the infantile type, is rapidly progressive and often fatal within 2 years after symptom onset. 9. Neurological signs. In Binswanger's disease, neurological findings include brisk reflexes, Babinski sign, gait apraxia, and emotional lability. In Krabbe disease, there is hypertonia, spasticity, optic atrophy leading to blindness, deafness, and peripheral neuropathy. MRI imaging findings. Binswanger's disease shows diffuse periventricular and deep white matter hyperintensities on MRI, T2 flare, lacunar infarcts, and brain atrophy. Krabbe disease shows symmetrical white matter changes, particularly in parietal and occipital lobes, with thalamic and corticospinal tract involvement. 11. Histopathology. Binswanger's disease shows arteriosclerosis, white matter rarefaction, loss of myelin and gliosis, proliferation of glial cells. Krabbe disease shows globoid cells, large multinucleated macrophages, and severe demyelination in both the CNS and PNS. 12. CSF and laboratory findings. In Binswanger's disease, cerebrospinal fluid, CSF, is usually normal or may show mildly increased protein. In Krabbe disease, GALC enzyme activity is markedly reduced in leukocytes or cultured fibroblasts. Genetic testing confirms the diagnosis. 13. Systemic involvement. Binswanger's disease is largely confined to the brain. It does not affect other organs. Krabbe disease affects both central and peripheral nervous systems and sometimes involves optic nerves and adrenal glands. 14. Risk factors. Binswanger's disease is associated with hypertension, diabetes mellitus, hyperlipidemia, smoking, and aging. Krabbe disease has no environmental risk factors. The only risk is inheriting two defective copies of the GALC gene. 15. Prognosis and treatment. Binswanger's disease progresses slowly over years. Treatment is symptomatic and focused on controlling vascular risk factors, blood pressure, diabetes, cholesterol, and supporting cognition and mobility. Krabbe disease has a poor prognosis, especially the infantile form. Hematopoietic stem cell transplantation, HSCT, may help if done before symptom onset, but otherwise treatment is supportive and palliative. Thank you. Have a nice day.